on our third session for mental health. It's going to be focused on cognitive behavioral therapy for depression. And we have Wayne here again with us today to go ahead and facilitate us through that conversation. So I will stop talking. And if you guys have any questions, feel free to drop a question in chat box, or don't forget that you can always interact at the end of the sessions for questions. Thank you.
Oh, hi, good afternoon again. I am waiting for the cursor to be in my control. I know it takes a minute. All right, so welcome to session 3 on the mental health sessions for CLearn. I am going to be talking with you today about cognitive behavioral therapy for depression. And I'm just going to do, like I have in the previous session, a brief review of the topics that we've covered so far in this series. So, in session 1, we talked about the collaborative care model and talked about how this is the model that's been developed that introduces a care manager in the care relationship for the management of behavioral health, or a care coordinator. And that the advantage of this care coordinator is to actually coordinate all the services that a particular client or patient may need to support improvement for depression or whatever mental health illness. And in doing so, providing support and also making sure that in between visits that this person is getting the support that is needed, getting information to inform the next visit with the primary care provider when it comes to making decisions for care. The care coordinator is also supported by a consulting psychiatrist who can discuss the care with the care coordinator, or with the primary care provider, or in some situations the consulting psychiatrist can be available to actually see a client briefly, particularly if things are not proceeding as well as one would have predicted. This entire process is supported by some sort of registry function that allows the care coordinator to follow along with a number of clients and see who's getting better, who's getting not better, and also to make sure that no one falls through the cracks. We talked about from this, how we can create a map of resilience around a client or a patient in this situation, where this person is surrounded by an activated network of care and support that is present and interactive. Last week, we talked about depression and depression symptoms, and we talked about how we move from thinking about depression as a series of symptoms to actually a collection of symptoms that interact to cause a significant amount of dysfunction. Represented here, of course, is the PHQ-9, remembering that not only does it list the symptoms of clinical depression as they are for the DSM-5, but also can really serve as a real resource for talking to other people, your clients and patients, about depression without having to use the word depression, and also using this to get a sense of how intense the symptoms are, and from that intensity, get a sense of how much the symptoms are actually affecting this person's day-to-day function. We also described that a way to look at symptoms of depression is to recognize that these may be grouped into emotional symptoms and cognitive symptoms and physical symptoms, and that these different types of symptoms interact with each other to cause significant or severe change in function or behavior. And we talked about how this again becomes a more functional way to think about how depression is affecting someone. And we also recognize that experience and research has shown us that, when it comes to screening folks for depression, and if depression is present, that it's never just depression, that depression comes along with a lot of other psychiatric and mental health comorbidities, and also some medical situations as well. And that the opportunity here is that if we're able to identify these things it is often treating the depression that becomes the gateway or the entrance point into addressing these other things that may be going on. And finally, we also talked about this model of depression called the cycle of depression, and how the social determinants of health could be involved in how depression shows up as a final common pathway. And the whole idea here is that the more information we have about what's contributing to the symptoms of depression, the more opportunities we have for interventions to try to get depression better. Then we spent some time talking about problem-solving therapy for primary care, and how problem-solving therapy is a very present-focused clinical therapy, and that as the person who is working with a client in this therapy, you're helping them to identify areas in their lives that can be helpful to work on, and being this person's advocate with them in terms of helping them come up with solutions, and then implementing those solutions, and then checking to see how those solutions did or did not work, and how we can use this process to adjust our attitude about what's working and what's not. And rather than thinking in terms of success or failure, we always think in terms of feedback from how the implementation went, and if this implementation was successful, using that by way of as an opportunity for a lot of positive reinforcement for using the skills. And if the solution didn't go as expected, using that as an opportunity to troubleshoot even further what may be some other ways of either approaching the problem, or recognizing that there may be other factors that came up that need to be addressed. So today we're going to talk a little bit about cognitive behavioral therapy, particularly for depression. And this is something of an introduction, because the training to become a cognitive behavioral therapist is actually quite intense and requires a lot of supervision and support. But we can talk about this in a way that is actually somewhat intuitive. And in fact, the discussion that we had about problem-solving therapy last week actually provides a really good structure for cognitive behavioral therapy. Now, you may recall from last week that I mentioned that when it comes to the treatment of depression, or at least the clinical treatment of depression, when it comes to the so-called psychotherapies and talk therapies, there are a number of options that are out there. And kind of the big divide in terms of what's available is something called psychodynamic psychotherapy, which is based in psychoanalytic theory, based on the work by Sigmund Freud and other people around looking at defense mechanisms and process of interaction with others, history of past relationships and how those things may be impacting how a person perceives their world and their relationships right now, and working through that to try to improve depression. And the other arm is actually the cognitive behavioral therapies, which are based mostly on present day thinking, emotions, and behaviors, and working with those to actually bring about a change in symptoms. Cognitive behavioral therapy is probably the most researched form of psychotherapy, with a number of clinical studies and outcome studies that it's shown that it can be effective for depression and other disorders. And as I mentioned before, it's not necessarily that it's more difficult to learn, but it is, as a psychotherapy, requires a fair amount of structure to make sure that someone's proficient in providing this type of therapy. Now, recall that this was the model of depression that we spoke about last week, that the depression symptoms can be categorized as emotional, cognitive, and physical symptoms that interact to bring about a change in behavior or function. And so one of the approaches or main ideas of CBT is that knowing that depression symptoms can be categorized this way, and that emotions and thoughts actually affect behavior to bring about symptoms, we can use the same formulation actually to bring about improvement and recovery in depression. So the process of cognitive behavioral therapy is just that. The cognitive part is looking at the thoughts that are present and addressing those, knowing that the quality of thoughts are very much affected by the emotions that are present, and vice versa, that these two then can inform behaviors, and that once we can become aware of how these things are happening, we can learn new behaviors to replace those to bring about improvement in depression. And so the main idea behind CBT is this phenomenon that our thoughts and how we think actually creates how we interact in the world. Or another way of saying it is our thoughts are very much inform our behaviors and how we affect the world. Another way of saying it is that our perceptions of what we think is going on around us very much informs the behaviors that we choose. I very often say to my patients that, when it comes to being treated for depression, no matter what mode of treatment is being used, the way we think about our lives and our relationships when we are perceiving those things through the lens of depression is very different than how we think about those things or behaving those things when we're not depressed. And this is, again, one of the main tenets of CBT, that we can essentially control our behaviors by controlling our thoughts. Now, cognitive behavioral therapy was actually developed in the late 1950s to early 60s and kind of developed along kind of two parallel tracks. One that was called rational emotive therapy, and that was done by a psychologist by the last name of Ellis, who kind of looked specifically at emotions and how they impact behavior. And then what we know of as cognitive behavioral therapy, particularly the modern version of cognitive behavioral therapy, was developed by Aaron Beck, who is still alive, who is the head of the Beck Institute in Philadelphia. And it's his work that's really informed this idea of how we can link thoughts and emotions to behaviors, and in looking at those things, bring about improvement in symptoms. So, other ways of looking at this. Here are some things that we know about the cognitive and emotional impacts of depression. So dysfunctional thinking may predispose to depression. In other words, there can be negative and characteristic ways of thinking and misperceiving that may predispose someone to becoming depressed. And it also can work in the opposite direction, that the types and qualities of thought that are produced by the brain by someone who is going through depression, can lead to more dysfunctional thinking. Our thinking is highly related to mood, and we know this even if we're not depressed. That the type of and the quality of thoughts that we have is very much affected by the type of emotional state that we're in. Thinking is highly related to activities one engages in. Again, this is something that even in the non-depressed state we know to be true. Activities are highly related to mood. Thinking is highly related to how one interacts with others. We are constantly evaluating our connections and our relationships with others consciously and unconsciously. And we're doing that through the process of thought. And social support is related to mood. And this, of course, becomes highly relevant for the purpose of this, what we're doing here in CLearn, where we're doing our best to help people develop networks of resilience and communities of resilience as well. So just one more slide to reinforce that the power of thoughts is in how they make you feel and act. This is actually a predictable phenomenon. So in other words, you can choose the manner in which you think. And it's quite often that when we're not in our ideal emotional states, that we can lose sight of the fact that even when we're not feeling at our best, we can actually make choices that can help us end up feeling better than we are in the moment. So the whole idea here then is to do our best when we're working with someone in cognitive behavioral therapy to improve awareness of either thoughts, behaviors, or emotions, and how those things are actually contributing to depression symptoms or sustaining depression. Using that awareness to come up with different action, and through that action, creating a change in symptoms. The reason I put it in this way is that it is quite possible for us to become quite aware of a lot of things that may be going on, particularly when we're depressed or anxious or whatnot. But if we're not doing that, using that awareness in the service of creating some sort of different action, then change doesn't happen. So this three-step process is actually very, very linked. In order to use that awareness effectively, that awareness has to result in some different action, and by definition, that different action will bring about a change. So what are we trying to become aware of? Our thoughts, our emotions, and our actions, reviewing those, coming up with alternatives, and then implementing those alternatives in order to improve symptoms. So again, you can already see that this is very similar to the discussion that we had about problem-solving therapy. So again, it makes the point that cognitive behavioral therapy as a therapeutic choice for treatment of depression is very present focused. We're talking about the symptoms that are happening right now and how they're actually impacting behaviors and lives right now, and focusing on changing those. It is very behavior focused. And this goes back to the point I made on last slide, which is that awareness has to be paired with a different action in order to bring about change. It also requires practice. And so one can think of depression and anxiety as a series of behaviors and a series of thoughts that are well practiced over time. And because they're well practiced over time, we get really good at thinking in those ways. And so like anything else, when we want to bring about a change, in that type of behavior, or to introduce a new behavior, it will first mean identifying that new behavior and practicing that, so that becomes more second nature than the old behaviors. And because of that, by definition, a client that you're working with through CBT, that is going to be required that this person do practice in between sessions with you. And so this therapy necessitates assignments of homework that are very specific, and that will be followed up at next sessions. Over time, with implementation and research, cognitive behavioral therapy has been shown to be effective not only for depression, but for generalized anxiety disorder, for post-traumatic stress disorder. And in fact, there are two specific types of cognitive behavioral therapy that are available for the treatment of PTSD. In some countries, for example, in the UK, cognitive behavioral therapy is actually the primary treatment for CBT, because it has been shown to be more reliable than the use of medications for improving PTSD symptoms. Panic disorder, specific phobias, fear of flying, fear of heights, fear of bridges. You can get social phobia, for example, substance use and gambling disorders, and also for eating disorder behavior as well. So there's a well-characterized literature out there on the research and the outcomes of CBT for the management of these symptoms or these disorders. Now, one of the things about CBT is that, in learning CBT and implementing it, there are certain techniques and processes that are used. And what's happened over time, is that recognizing that not all environments are optimal for implementing the full course of CBT for a particular disorder, it has been shown that if we're able to separate out some of these techniques, then we are able to actually bring about improvements as long as they are applied in a very specific way and as long as they're applied with specific intentions. So problem-solving therapy is actually evolved out of a technique from cognitive behavioral therapy, something called pleasant event scheduling, progressive muscle relaxation, and that comes from the CBT for managing things like panic disorder. And the process there, of course, is to go through this exercise with a client in the room of tensing and relaxing muscle groups progressively, so that the person actually starts to learn what it's like for their body and their muscles to feel tense, particularly around anxiety. And in learning their responses, they can then want to be familiar with them, and that can become the place to begin to address how to manage anxiety in a particular situation. And then there's this thing called exposure and response prevention, and that also comes out of the CBT work for anxiety. And the whole idea here, again, is to find a way to recognize what are some things in the environment that can trigger symptoms, for example, panic symptoms, or sometimes even depressive thinking or depressive thoughts. And if we're able to do those and place those in a hierarchy in terms of intensity around emotions or behaviors, then we can start with the lowest intensity and learn how to manage that. And as we become successfully managing that, we move on to the next symptom and the next and the next. So you can tell already that as we talk about these techniques and processes, what they have all in common is that they are very organized, they require practice, they require follow-up, and they require a very active engagement and back and forth with you and your client. This is not a process. This is not a passive therapy in any way. One of the things that we've learned from this work is that improving interactions with people improves mood. Now, as we're thinking about C-Learn and the process of developing resilience, or the process of recovering from disasters, that is a situation that necessarily requires us to be interacting with each other, right? Things that we know, negative thinking interferes with good interactions. It is important to improve social networks. Assertiveness, and what I mean by assertiveness is communicating in ways that actually helps bring about the results that we want and invites other people to help us. Improving problem solving with others and learning how to build trust. I mean, you can think of those 4 or 5 statements there as what would be described as good qualities of a functioning network or qualities of resilience. So as I mentioned, that when it comes to CBT for depression, there are several studies that have been done over the years to prove that CBT as an intervention for depression is very effective. There are a number of studies that have compared CBT to other types of psychotherapies and clearly show that CBT is superior in terms of outcome. We can also, CBT is also being compared to medications for the treatment of depression. And for most people with depression, outcomes are similar. But for those who are severely depressed, that may not be the case, and that makes sense because those who are severely depressed may be so behaviorally inactivated that it would be hard to get started and hard to maintain. So this is where combining medications with CBT can actually be very helpful. Or starting with medications, waiting for some improvement, and then engaging CBT can be helpful as well. So already we're seeing that there can be many ways to actually attack the same problem. Cognitive behavioral therapy is also very helpful in preventing relapse. And this gets back to this definition of depression as a series of behaviors that brings about changes in a person's environment and therefore changes in their symptoms. Once a person is better from a depression episode, particularly with using CBT, we can then go back and review with that person, what are the things that you did over time, over these few weeks, that actually helped you get improvement in your depression. And that can include things like making sure that daily activities happen, getting engaged back with community groups, getting in touch with family, finding regular time for self-care. All of those things become very easily identifiable and then can be used to prevent relapse of depression symptoms. So going back to this idea that changing dysfunctional thinking can improve mood. So I mentioned earlier that one of the ways to think about this is that looking at the world through the lens of depression is very different than looking at the world through the lens of non-depressed, because the way we perceive and think about things and our accuracy of perceiving what's going on around us is different. one of the functional ways to think about depression, particularly when you're meeting your clients for the first time, again, is not only to think about what the symptoms are, but how are these set of symptoms affecting the way this person is interpreting what's going on around them? And you may have had either professional or personal experience with this, where someone's interpretations of what things mean or what people intend or how things relate to them personally can be very, very different when they're depressed, and in fact can maintain and sustain depressive ways of thinking. So cognitive behavioral therapy becomes a strategy for us to, one, identify what those ways of thinking are, and two, help that person develop alternatives based on reality, and therefore, three, change how they interact with others and therefore improve their symptoms. So the example that's given here is, if I am too ill to work, I'm useless. An alternative that can be worked on or worked through is something like, although I'm unable to work, I am a good friend and a good member of the community. So we move away, in this example, from this all or nothing thinking to a more nuanced thinking that actually more correctly matches the reality of the situation. Engaging in person in pleasant activity improves mood. And this can be one of the hardest things to do, particularly in the beginning, to try to get someone to try to engage with pleasant activities because they really don't feel pleasant at all. And in fact, sometimes when you're evaluating someone with depression symptoms, they've been mentioned that there were things that they used to do that they really enjoy that they just really don't have any interest in at all. And they can use the fact that they don't have interest in those things to further support the idea that there's something wrong or there's something wrong with them or that the situation is hopeless. So as I mentioned last time, one of our functions when we're working with clients, particularly in the beginning, is to recognize that while they are feeling hopeless, we are the people that can carry the hope for them until they start to engage again. And so one of the ways that we can actively do that is to support this person to engage in pleasant activities, even if at the moment they feel that they can't do it, or even at the moment that they feel they don't want to. What we do know is that if we are able to help a person do that, they can actually experience feeling better in spite of themselves in that way. So this is a chart to recognize again that, the harmful thoughts that we can experience when we're having severe depression and anxiety are typically not accurate, they're typically not complete, and therefore typically not balanced. This can become a process, an ongoing process of working through with someone, particularly in the beginning. And here are some examples of, of what are inaccurate, incomplete, and unbalanced thoughts. So you are recognizing already that cognitive behavioral therapy and things like problem-solving therapy require us to be very organized in our data gathering, particularly at the beginning. So as a way of thinking through this, in the beginning with working someone, you're really trying to get a sense of where this person is at. And there are a number of ways of doing this. One way of doing this is to use the PHQ-9 that we talked about before to get a sense of where they are, and then use it in the interim to see how things are improving. Another is, if you want to get very specific, to have this person carry a mood scale or mood chart similar to this. And this becomes a useful tool to use at each session to get a sense of if things are improving or not. Going back to the whole model of collaborative care and using a data registry to support making sure folks are getting better, this could be a data point for for your clients as well. So as we start to think about implementing the collaborative care model, implementing things like problem-solving therapy or cognitive behavioral therapy, we can get used to this idea of developing a good set of data. Now, we've been focusing on the PHQ-9 because that's one of the ones that's available for depression, but there are scales that are available for bipolar disorder or PTSD that can be used either instead or in conjunction, depending upon how you want to approach working with your client. Pleasant activities can increase resilience. And of course, in Sealand, we're all about improving and finding resilience. And this gets back to what I mentioned earlier, which is that often once we start on the path of engaging in one pleasant activity, it can learn to other things that are pleasant and that are typically unexpected. And this is just a human phenomenon. We just know that once we get the spark started, that spark will grow pretty quickly. In general, more helpful activities lead to more helpful thoughts and feelings. It is also important to keep in mind that a person can have some choice in thoughts and also choice in activities. So again, one of the things that's going to be important for you to reinforce with your clients is that although you're not feeling up to your best, or although you're feeling bad, even in this moment, you do have a choice about what you can do next to help improve your mood or help improve your situation. Um, Activities are linked to mood. When you feel down, it may be hard to find the energy to do those activities, but when you are not feeling down, it's not. But you can use that as a process to bring about a transition. Sometimes that whole process of getting someone to engage in something when they really didn't feel like doing it and having that go successful can then be used to help motivate that person to further activities. It could be that once they realize that this is something I did successfully, that may spark, some hope as well. So types of pleasant activities. Think about activities that you can do alone, for free, with other people, quickly and simply. This is where, if you are very in tune with the person that you're working with, and if you share communities, or you are in tune with some of the things that are available in communities, this is where you as a therapist, or as a care manager, as a community worker, can really, really help. It is helping folks engage in activities that distracts them from the negativity that they're experiencing, or the sadness that they're experiencing, is one of the most powerful interventions that can be done in a cognitive behavioral therapy kind of way. It is good to have a variety of activities, and what I mean by that is activities that you can do alone, or activities that you can do with other people. And not only is it good to have a variety, but it's also good to have a balance. Because some of us may have more energy for different types of activities than others. Activities that are inexpensive or free are good. Not only important, they're good. And activities that don't take too much time are also important. Sometimes the thing that we need to think about for someone who's struggling with depression is that their stamina, either from an energy perspective, or their stamina for interacting with people, is a lot different. And so it may be helpful to actually think about the duration of some activities, to kind of get a person started, but also allow them to get some rest and recovery. In a project like CLearn, particularly when we're talking about recovery from, something like a disaster, it does become important to help folks remind themselves of the things that are healthy to do in terms of taking care of themselves. Just thinking about the possibilities around, loss of a loved one, or displacement from a home, or loss from a home, or any things like that. Self-care can get easily lost. So I would say that in your preparation for working with clients to improve their resilience, one of the things that it could be helpful for you to think about specifically is what are some specific things I can help someone get back to in terms of taking care of themselves, so that they can take care of their lives. Right. And so we listed 3 things here, but there may be some very specific things that come up for you as you think about recovering from a disaster, recovering from a loss, that you can think of as well. And I think it may be worth taking some time, trying to figure those things out for yourself, and talk among yourselves about some ideas. Same thing around trying to find pleasurable activities for some folks. Also, we want to make sure that we find things that are doable and that seem relevant for a person as well. Learning activities, things that give you a sense of accomplishment. I think I think any activity that we can actually successfully help someone engage in, particularly when they're feeling depressed and anxious, will lead to a sense of accomplishment. We talked about this in a way last week, where we talked about the idea that we can think of life as a series of problems or challenges to be addressed or solved, and that in life there are different types of challenges and different types of problems. But what we do know is that if we are able to successfully meet those challenges, that brings about not only a sense of accomplishment, it can significantly improve self-esteem. It can actually start to bring more hope. So I think for any of these, I think this whole sense of accomplishment can work across all sorts of activities. And again, finding meaningful activities that fit your values, fit your purpose in life. And this is where things like participating in church activities, social activities, political or community activities can really help reinforce and bolster that sense of community and help improve resilience. This here is just another way of organizing the problem-solving method that we talked about last week. And again, it reinforces this idea that engaging these types of therapy are best done when it's very organized, when the data is written down, and the data can be referred to again. And this is not saying that that every little thing needs to be written down or there needs to be a piece of paper for everything, but the whole idea with all of these therapies is that you're helping this person engage in a number of types of solutions or a number of different behaviors. You want to find some way to record information so that you can reliably go back to it, not only to get a sense of what's been accomplished or what hasn't, but sometimes going back, with this information can help a person see how far they've come. One of the things that's been really gratifying in the work that I did in the collaborative care model was, in keeping track of information and data points over time. At some point when that person is improving, someone will say something to you like, you know what, I'm really not sure where this is going. I'm really not sure that I'm improving. And if you actually have the ability to actually give this person real-time past feedback, either in the form of, here's what your PHQ-9 scores were 3 weeks ago, and look at this is where you're at right now, or if you had the ability to graph that, or if you kept track of the problems that they were solving, and you can use all that by way of showing in very direct and evidential kind of ways that yes, this process seems hard and sometimes it feels impossible, but you actually have accomplished a lot. And again, that can go a long way with instilling hope. So we found different ways to talk about this today, and previous sessions. That one of the ways out, or sometimes one of the ways through depression, is actually creating and reinforcing healthy relationships. And in fact, this is entirely what the C-Learn project is about. Because we do know that one of the things that can happen with someone with severe depression is social isolation. And while in that moment the person who is going through that process of social isolation may feel, for example, that they're being less of a burden on other people, which is an interpretation that can happen with depression. What we do know is the complete opposite, that having community and actually engaging in community will improve symptoms, will improve depression, will decrease mood symptoms. And again, this is the central idea around looking at something like C-Learn. So when you have less contact with other people, you might feel alone, sad, angry, like no one cares. That whole self-fulfilling prophecy. I don't believe anyone cares, so I'm going to stay away from other people. And because I'm staying away from people, it means that no one cares. You can see the circular reason that can happen there. But of course, if you're able to engage and those interactions are positive, the more likely it is that you'll be less resistant to the idea of interacting with others, or become pleasantly surprised that, what, I actually feel better interacting with people. So this is another example of what it means to help a person recognize who and what other resources are out there for them to reach out to if they're not doing well, or who or what resources are out there to support a person to continue to feel well. Um, I invite you to find whatever ways that you can as you're working with clients to help people, keep track of contact information for people and resources that are important to them. This is one way of doing that. Another way of doing that is this. You can easily create a chart out of something like this, and fill it in with specific names and numbers, for resources. Like anything else, when it comes to working with someone, in these intimate kinds of ways, the essential skill, whether it's cognitive behavioral therapy or problem solving therapy or psychodynamic therapy or psychoanalysis or IPT, all the other acronyms that are out there, the core essential skill is to find a way to listen well. And this works for not only those of us who are mental health workers, but this could also work well for our clients and patients. One of the things that we are doing when we're working with clients and patients is actually teaching them how to communicate effectively. How to talk about feelings effectively, how to have conversations about difficult and painful topics in ways that are actually helpful and constructive. So while we are doing the things that we do to help this person, we are demonstrating how these sorts of things are possible. And the more and more we do this, the more and more our clients would then take on that behavior as well. So as you are supporting your clients to interact with others, to get back in touch with others, to maintain their networks, one of the essential skills that you can be teaching them is actually how to listen well. And so if we can do this, you can do this by way of kind of the implicit model, as I just described here, meaning that as a byproduct of you doing that effectively, they'll learn how to do it. But you may also want to check in with them, specifically about what it means. How do they want to go about, listening well and engaging with others? Because one of the things that we know that can happen with someone who has been struggling with depression and anxiety and also PTSD is that their ability to be patient sometimes is gone. The irritability shows up a lot, because of the tiredness and the low energy. Someone can feel very ineffective in a moment, trying to talk with someone. And so this could be one of the ways that you approach helping this person, learn how to re-engage in effective ways with people that are important to them. And I think that brings us to the end of this session for this week. So I think next week is going to be our last session in this series, and we will talk very specifically about the medical and medication management of depression. And we'll talk about how that also connects with the problem-solving therapy, cognitive behavioral therapy, and how this can be an important part of the resilience maps that we've been discussing. So at this point, if there are any questions or anything more we want to discuss, I'm happy to do that.
All right. Well, if you guys don't have any questions, I will see you back tomorrow, same time, and we will resume with disaster preparedness.
Okay.
Have a great evening or afternoon, rather.
Thank you.